I'm a professor of neurology at Albert Einstein College of Medicine, and I also run the Sleep-Wake Disorder Center at Montefiore Medical Center, which is the teaching hospital for the university. I've been involved in assessing sleep disorders for many years, and I've had a particular interest in the area of the hypersomnias that includes narcolepsy and idiopathic hypersomnia. I've done research in the area. Some of it has been pharmaceutical company research where we've looked at the effects of various medications on the major symptoms of narcolepsy, particularly excessive daytime sleepiness and cataplexy. Well, it's important to recognize that narcolepsy is not just a disorder of excessive sleepiness. I think of it in terms of the three major features of narcolepsy. There are patients that all have excessive daytime sleepiness, but then there is abnormal REM sleep phenomena or abnormal dreaming phenomena. And the most evident of these is cataplexy, which is the emotionally induced muscle weakness where people tend to fall to the ground. And that's a partial manifestation of the dreaming sleep, the REM sleep. But in addition to that, there are two other symptoms that are very prominent that are associated with disrupted REM sleep. One of them is sleep paralysis, where people, as they're falling asleep or awakening, have a feeling that they're unable to move because they get the atonia of REM sleep occurring at those times. And the other feature is the hallucinations. And there are two types of hallucinations predominantly. There's the hypnagogic hallucinations that occur at sleep onset, and then there are hallucinations that occur when the patient's awaking. Now, typically, when we go to sleep at night, individuals that don't have narcolepsy don't go into the dreaming sleep at the beginning of the night. We all tend to have most of our dreaming sleep towards the end of the night, so it's not uncommon for us to awaken from the dreaming sleep or the REM sleep in the morning. And that's when we can have some hallucinatory phenomena. We may be in a half wake, half sleep state, and if somebody's had some disruption to their REM, they may see some images. But it's more common in patients with narcolepsy, but the area that's most specific to narcolepsy are the hypnagogic hallucinations, those that occur at the beginning of the night, because healthy individuals do not go into the dreaming sleep then. But if patients with narcolepsy will start to fall asleep and have some components of the dreaming sleep, the REM sleep, and it's at that time they may see images while they're still awake. And these hallucinations that they can have can vary a lot, but in most cases, they tend to be very unpleasant hallucinations. The main symptoms of narcolepsy, the sleepiness and the cataplexy, tend to overshadow these abnormal dreaming phenomena. And so patients are often very hesitant about talking about hallucinations for the obvious reason, because they're concerned that the physician may think that it's a psychiatric problem, whereas, of course, narcolepsy is a neurological problem. And so they often don't bring it up, but occasionally we'll get patients that come to us that are extremely upset with these dream phenomena. And it may be more than just the hallucinations. They actually may have very frequent vivid dreams. They have nightmares, frightening dreams, all sorts of abnormal dreams like delusional dreams, lucid dreams, dreams of flying, what we call out-of-body experiences. So a lot of abnormal dream content can occur at night, but when they have these hallucinations, they may be very unpleasant. They may feel that as they're falling asleep at night, that somebody is in the bedroom. They may feel as though things are crawling over them or somebody is about to attack them. Or there's often a feeling of falling. I mean, it's not uncommon, even people who don't have narcolepsy, as they're falling asleep, sometimes get a feeling that they're actually falling, and becomes even more definite in the patient with narcolepsy, where they may feel they're falling into a hole, or they may feel that they're flying around in the room. So very often, very unpleasant ones, sensations, but they don't often bring it up to the physician, so they don't often get treated. But the medications typically used for narcolepsy The daytime medications, because physicians will tend to prescribe medications to keep patients awake during the day or to treat the cataplexy during the daytime. And they don't pay much attention to what's going on at night in patients with narcolepsy. But we now recognize that this disrupted nocturnal sleep is a major factor in narcolepsy, and we're paying more attention to it. And fortunately, now we have medications that can address those nighttime symptoms that these patients have. Lumryz is a medication. It's a form of oxybate, which is a derivative of gamma hydroxybutyrate. And it's a medication that's taken at night that keeps us asleep. Now, the older forms of oxybate, you had to take them twice at night. So you had to wake up in the middle of the night and take a second dose because they had a very short half-life and it would wear off in the middle of the night and the patient would spontaneously awaken and have to take a second dose in order to get back to sleep. Lumryz is a new form of it. It's called once nightly oxybate. And the advantage is that you just take it once at the beginning of the night and it keeps the patient asleep through the whole night. Now, there are many medications that we use in narcolepsy, but oxybate is the only one that improves nighttime sleep. And not only does it improve sometimes these patients may have difficulty falling asleep. It'll help that. They awaken frequently through the night. It helps that. It reduces brief arousals and gives them a more consistent sleep at night. And in addition to that, it can treat these abnormal REM sleep phenomena that I was talking about, this abnormal dream content, the hallucinations, the sleep paralysis, the vivid dreaming, and the frightening nightmares. So it works by a very different mechanism to other drugs. I mean, most of the drugs that we've used in narcolepsy have tended to be drugs that are alerting, that tend to stimulate wake-promoting neurons throughout the body directly, so that they've been sympathomimetic, such as Ritalin and amphetamines, or they've affected dopamine, like modafinil, or affect norepinephrine, such as the drug solriamfetol. But Lumryz and sodium oxybate is a different mechanism. It affects the GABA B receptor in the brain. But by doing so, it does help to stimulate the alerting neurons throughout the brain and also will help to affect REM mechanisms and correct that abnormality that we see in REM sleep that's caused by disruption of the brainstem REM mechanisms. In particular, with regards to the hallucinations, I presented at the Sleep 2025 on the effect of this medication, Lumryz, on hallucinations. And there's been very little research done on hallucinations over the years. I mean, the focus, as I mentioned earlier, has really been on the excessive daytime sleepiness and the cataplexy, and no one has really addressed it. Now, this medication, Lumryz, was studied in a 13-week double-blind placebo-controlled study, and it showed it to be a very effective agent for the typical symptoms of narcolepsy, the sleepiness and the cataplexy. But in addition, there was information collected on hallucinations, and a post hoc analysis of that information was the information that I presented at the sleep meeting. So what was assessed, these patients had an assessment of their hallucinations over a 2-week period prior to the study. And then the hallucinations were assessed at the various intervals throughout the study and at the end of the study. And what was found was that there were a variety of hallucination types that were recorded. And we used definitions for 6 different types that patients could indicate whether these were happening or not. And we found that there was an approximately 50% reduction in the patients that were taking Lumryz compared with those that were on placebo. So it was a big decrease in the number of episodes. There were over 12,000 hallucination episodes recorded throughout the study. So there was a lot of information. And what we found was that the ones that were most improved, over approximately 50% improvement in these hallucinations, were frightening ones like being attacked or falling into a hole or flying through the air. And most of the hallucinations that we saw in the study tended to be the ones that occurred at sleep onset, the hypnagogic hallucinations, compared with the hypnopompic. So a large reduction in the hallucinations, particularly in the treatment group. There was a reduction also seen in the placebo group, but the reduction was greater in the treatment group. And in particular, those frightening types that I mentioned, they were about 50% reduced. So as I mentioned, this is really one of the first studies that's really looked at these hallucinations that can occur in relationship to sleep. And it's an area that physicians tend to overlook because of the main symptoms of narcolepsy that are talked about so much, the sleepiness and the cataplexy. They tend to overlook the abnormalities of a dream sleep that occur at night that may be very bothersome and concerning to patients. So I think the important thing about this is, one, I mean, we saw such a huge number, over 12,000 hallucinatory events, and any one of these can be very disturbing and frightening to a patient. So hopefully this information will indicate to physicians, one, to take closer attention to disturbances that are occurring at night, and particularly with these REM phenomena and the hallucinations, and the recognition that some of these hallucinations may be very unpleasant, such as being attacked or falling into a hole, and very disturbing to the patients, and that there is treatment that can make a big difference when patients have these symptoms. Some patients may suffer from a lot of these symptoms. Other patients may only have a few and they may not be that bothersome. But as I mentioned earlier, a lot of these patients don't like to talk about it because they're scared that the clinicians will think that this is a psychiatric and not a neurological problem. So physicians need to ask about it and recognize the fact that there are treatments available that can be helpful.